The Surgery Center of Oklahoma was founded for two or three different reasons. One, we realized we were leveraged and controlled by people who really did not have the patient's interests at heart, whether medical or financial.
Welcome to the License to Lead podcast. I'm Patty Fay. This podcast is for physicians or anyone who thinks healthcare needs a transformation led by physicians. License to Lead means that physicians are charged with and must be in charge of guiding the vision and the culture of healthcare systems. Hello, everyone. This is Patty Fay. My guest today is Dr. Keith Smith, a board-certified anesthesiologist in private practice since 1990. That, however, does not even begin to tell his story. In 1997, he left his hospital-based practice to co-found the Surgery Center of Oklahoma, a surgery center which takes no insurance or government reimbursement. None. I read about Dr. Smith's innovation in Dr. Marty McCary's book, The Price We Pay. And by the way, I re-recorded this introduction after Dr. Smith demonstrated the correct way to pronounce Dr. McCary. The renowned surgical center is now owned by over 40 top Oklahoma physicians and surgeons. Dr. Smith is the medical director, CEO, and managing partner, and he continues to have an active anesthesia practice. In 2009, Dr. Smith launched a website that displayed all-inclusive pricing for various surgical procedures. And this pricing and the utter transparency of it garnered national news media attention. When you go to the pricing tab on the website, it takes you to an outline of a human body where you can click on whatever body part maps to the part of your body that needs surgery. For instance, click on the elbow and you'll get a drop-down menu with 8 surgeries listed and the all-inclusive price for your elbow arthroscopy or ulnar nerve transposition. The price includes fees for the surgeon, supplies, facility fees, and for the anesthesiologist, the whole kit and caboodle. Dr. Smith has been on CBS, NBC Nightly News, CNBC, Fox and Friends, and has been profiled by the New York Times, Time Magazine, Forbes, and others. He's clearly a spokesman and advocate for patients and for the medical profession. Dr. Smith, welcome to the License to Lead podcast.
Thanks for having me.
It's terrific to have you here. Would you go ahead and give me a thumbnail sketch of your current role, and feel free to make repairs with anything that I messed up in my introduction.
I think your introduction was complete. I do have an active full-time anesthesia practice and also run the Surgery Center of Oklahoma with Dr. Steve Lantier. I'm co-founder of the Free Market Medical Association, the brainchild of my friend Jay Kempton. We're trying very hard these days to just really spread the gospel of free markets and how everyone in the health industry needs to embrace the same discipline that all other industries in the United States have to endure. We're judged by the market either very harshly or very kindly in the service that we provide and the price attached to it.
So I hope that we'll do a deep dive into the culture and what is really going on at the Surgery Center of Oklahoma. But maybe for starters, you could talk about what instigated your decision to start the Surgery Center.
Well, I did have an anesthesia practice in the big hospital systems between 1990 and 1997. I think when I realized that the people doing the work were not being paid fairly, not being provided what they needed to actually take care of patients in the way we thought they should be taken care of, yet the rising administrator class seemed to be growing and making even more money. It just didn't seem right. It didn't seem right that the hospitals and the people who ran the hospitals were thriving, and the physicians and the nurses taking care of the patients were struggling. This all started back in the early 1990s with the institution of the resource-based relative value scale, which really tipped the scales in favor of the administrative class and against everyone else, patients included.
Could you explain that a little bit more about how that tipped the scales towards the administrative class?
Yeah, so when I started practice in 1990, I'm cardiac and pediatric fellowship trained, and I came to Oklahoma City to do hearts. That's what I wanted to do, was cardiac anesthesia, and also loved pediatric anesthesia. And I was paid by Medicare $1,100 for an anesthetic for an open heart surgery in 1990. In 1992, George Bush the lesser, as I say, introduced and helped usher through the resource-based relative value scale. That was the brainchild of a Harvard economist who thought that he, along with his team, could assign a price to every service, every physician in the United States provided to Medicare beneficiaries. So they decided that a cardiac anesthetic at that point was worth no more than $550. Not satisfied with RBRVS 1, they had round 2. And so in 1993, the last cardiac anesthetic I delivered, I was paid $285 for a 6-hour procedure. I was paid $78 for the anesthesia services required for a knee replacement for a Medicare beneficiary. So, you figure out after you pay taxes and overhead what you're left with. It was obviously just a sham. So I decided to just quit filing claims. It didn't seem right to legitimize an illegitimate system. So I just quit filing claims. If it's charity, that's fine. I'm charitable, but I won't do it at the point of a bayonet. So I just quit participating.
So I don't remember the anesthesiologists back in the 90s dressing like paupers and being totally broke. So how were they making money? What was going on?
What happened was, it wasn't just the anesthesiologist, it was a radiologist, the pathologist, the emergency room doctors, all of the surgical subspecialties. They jacked their rates up on everyone else. So, everybody had really pretty reasonable charges until the federal government knocked the bottom out of reimbursement for Medicare and Medicaid patients. So physicians responded by seeing fewer Medicare and Medicaid patients, primarily Medicare patients. They limited access, and then they jacked up what they charged everyone else. So they cost shifted.
Yeah.
And I didn't think that was fair to someone that was not a Medicare beneficiary. So I just decided I'm not going to deal with Medicare at all and charge everyone I do deal with fairly. And if someone who's on Medicare comes along, I just won't charge them at all. And these prices they attach to the procedures were all wrong. It's no different than PPO networks. They have this top-down imposed pricing, and it's all wrong. It's either too high or too low. The only legitimate pricing that can ever exist is determined in a competitive market economy. They'll never achieve what's called the market clearing price, where the buyer and the seller are both at their best advantageous place. I decided not to play that game, and the hospitals continued to make a lot of money and continued to do well, continued to complain that they were going broke. Physicians that I was working with were not being paid fairly. The PPOs took the lead when Medicare slashed fees, and all of the carriers, all of the insurance companies did the same thing. So they cut fees because they knew they could whittle it down, almost down to what Medicare was paying, maybe a little higher.
The door was kicked open, huh?
It was. And so once again, here you got all the nurses and the physicians, and they're taking care of patients, and they're now being paid less, actually less, not inflation adjusted less, really less. Expenses didn't go down. And the hospitals did well, and they started buying physician practices, and everybody was a loser except the big hospitals. So it was time to get out of that.
And how was it that the big hospitals, or the administrative class, as you referred to them, how is it that they were winning? What was happening in that regard?
I can answer that with a story. About the time I came out of anesthesia training, anesthesiologists had become very aggressive in managing patients' postoperative pain. And I was trained to do that. And I worked with an orthopedic surgeon who was extremely busy. And he really liked that, his patients didn't hurt as much as they had in the past. So an insurance company, an HMO, came to the hospital where he and I worked, and they sat down with the hospital and said, listen, we want to cut a deal so that all of the patients that we have under our umbrella come here for their orthopedics. Hospital said, that's great. Hospital worked out their deal. They were happy. They brought this orthopedic surgeon in, and they offered him a deal that was very lucrative, actually. And then he asked them, what about anesthesia? And they said, well, we don't care about anesthesia. And he said, well, I care about anesthesia because it's made my life better. It's made my patients' lives better. You have to make sure you're taking care of them. Well, it doesn't matter. I mean, one's the same as the other. And he goes, no. He said, you take care of the anesthesia guys I like to work with, and then let's talk again. That's a conversation that is very unique. It was very unusual. What typically happened was the hospital made their deal, and they didn't even talk to the surgeon, much less anesthesia. So the hospitals would have their conversation with these HMOs and these big insurance carriers, make sure that they were financially taken care of, everyone else be damned. And that is sort of the way things have gone since the early 90s. And that's how the hospitals continue to do well, and everybody else was just left huffing and puffing.
We'll circle back with what's going on currently with hospitals and obfuscation of prices and the harm done. But maybe to reveal a little bit more about what you're up to, can you give us a good picture of what is the Surgery Center of Oklahoma?
Well, the Surgery Center of Oklahoma was founded for 2 or 3 different reasons. One is some of what I just explained, that we realized we were leveraged and controlled by people who really did not have the patient's interests at heart, whether medical or financial. Also, Steve Lantier, my co-founder, he and I really didn't want to work with bad surgeons. Whenever you're in a big hospital and you're taking call, you get a call in the middle of the night, and if the hospital has given privileges to a surgeon who is awful, and you're on call as an anesthesiologist, you're obligated to work with them. And we really did not want to do that anymore. We felt like accessories to a crime whenever we enabled some surgeon who we thought was unethical, incompetent, or both. So we also started the Surgery Center because we didn't want to work with surgeons that we would not let work on us. We just felt like we had to take too many showers in the day to get over whatever it is that we had participated in. So we opened in 97 with the idea that we would provide the highest quality care at a reasonable price, and that we would tell patients what they were going to pay us before they arrived. We knew that was going to be a weird conversation, and one which made some patients uncomfortable, but we felt obligated to let people know before they arrived at the surgery center what they were going to pay or what they were expected to pay. And that way, there never were any misunderstandings about money. And a lot of these people did not have insurance. And we would just tell them over the phone when they ask how much is hernia surgery, how much is this breast biopsy or tonsillectomy, whatever it was, total knee replacement. We would just answer their question over the phone, and then they would come pay that amount, and they knew they were done.
How did you have any idea what anything cost?
Yeah, it's extremely complicated. So I would call a surgeon and ask them how much they wanted for their professional fee. None of them knew, but I told them to go figure it out and let me know. Otherwise, I would assign a price for them, and then we would adjust going forward if they thought I was wrong. As an anesthesiologist, I basically billed for my time, and I knew how long all of these procedures were going to take within limits. And then for the surgery center, I just priced that like a general contractor's time and materials. So we know what supplies the surgeons are going to use to perform certain procedures, and we know how long they're going to take. It's not even algebra. You just add those things up and you get your price, and then you go with it. And then after the surgery is over, you look back and was I right? Or was I wrong? Was I too high? Was I too low? And then you adjust. So that's how we do it. That's how we do it today.
Huh.
Except now, whenever I create a new price, we just post it on the website for everyone to see. And then I reserve the right to change those prices once a year with anyone, like a self-funded employer that we deal with. And I've only raised 3 prices since we opened in 1997, and I've lowered many.
Really?
I've lowered many more. Yeah.
Really?
So this.
So why have you lowered prices?
Well, so I would be more competitive in the marketplace.
Okay.
And whenever a vendor comes to us with a solution that saves us money, I pass that on to the buyer. So I pass it on to the patient or their self-funded employer. We don't really look at them as buyers or vendors as much as partners when they're self-funded companies. So if we're extended some olive branch by someone who normally charges us more, I pass that on to the buyer. And you can only imagine the goodwill that that's created over the years.
And the buyer generally is somebody who's shelling out cash because they have no insurance, or it's like a self-funded employer.
That's right. Or a cost-sharing ministry. That's our biggest representation of buyers. We also have patients that have insurance, but whose deductible is higher than our entire bundle fee.
Wow. Can you give an example?
Yeah. So it's not uncommon for a procedure price that we have listed online to be 1/6 to 1/10 what a so-called not-for-profit hospital would charge for the same thing.
Whoa. What are the repercussions of all that? That must really be interesting in Oklahoma City.
Yeah. I mean, whenever patients come to the surgery center, I always ask them, what was your next best price? Because these hospitals are in a market, whether they like it or not. They now are in a competitive market, and not just here in Oklahoma City. On any given week, most of the patients that we see are from out of state. And most of those are from states like Wisconsin and Oregon and Utah and Alaska, because they find our price and they go, okay, now this carpal tunnel surgery in Idaho is $15,000. And this carpal tunnel surgery at Surgery Center of Oklahoma is $2,750 all in. If it's $15,000 in Idaho, think, okay, I've got a Blue Cross plan with a $7,500 family deductible, and then I pay 20% over that until $10,000 or $12,000. That's not hard math. They come to Oklahoma City, pay $2,750 and save a lot of money by paying for the entire surgery. So that's just one example.
Oh my goodness. Maybe it's worth doing a bit of a detour into the obfuscation of real costs by hospitals. And that's what this is all about, right? It's this trick that they're playing, crank up the stated price on the master.
That's right.
And then we're giving you a discount, but basically the patient is paying a ton. And the real tragedy is the impoverished person who doesn't have any insurance. Then they get this outrageous price, which is maybe just in place as a ploy.
I think the latest figure I read is 60% of all bankruptcies are medical. 75% of those have insurance.
Wow. Really?
Yeah. So it doesn't even matter if you have insurance. But the game you're referring to is something we knew was lurking out there, but we didn't understand it. And when I posted the website in 2009 with all of our prices, we were hoping that by showing our prices, we would somehow begin to understand this scam. Because the thing that never made sense to us was why insurance companies did not want to work with us. Because you think, okay, the insurance company collects premiums and pays claims. And if it's cheaper and better, which we were, then they make more money. Why wouldn't they want to work with us? And the answer is because they make more money not working with us. And the mechanism was a little hard to discover, but I had 2 friends in the self-funded industry that helped me figure this out and kind of put the pieces together. But basically, a hospital, and I did a video on this called the $100 aspirin, if anybody wants to watch it on YouTube.
We'll put a link to it in the show notes.
Okay, so a hospital charges $100,000 and they collect $20,000. they claim that they lost 80,000. Now, it doesn't matter that the 20,000 they collected covers a cost of probably 2,000. So they really made about an $18,000 profit, but they claim they lost 80,000. And this $80,000 loss they claim helps maintain the fiction of their not-for-profit status.
They write it off then as community benefit because
that's right.
They're losing $80,000 on whatever the service was.
Yeah, so they're making money hand over fist, but claiming they're losing money all the time. And that way they don't have to pay any tax. That's what not-for-profit means, is don't pay tax. Most people don't know they're making profits. They just don't pay tax.
I've started referring to them as tax exempt organizations.
I call them don't pay tax hospitals.
Okay.
And then, and by the way, the hospitals claim they lost 80,000, and then that 80,000 goes into a bucket that's sent off to Washington, D.C. and forms the basis for a kickback the hospitals receive to the extent they claim these losses. And that comes in the form of what's called disproportionate share hospital payments. That's also called uncompensated care payments. That's what that is. Mm-hmm. The insurance companies play along because if they reduce a bill from 100,000 to 20,000, they claim that they've saved someone 80,000. And that usually is a self-funded employer. They would then tell the self-funded employer, per the terms of our agreement, we are due a commission on that 80,000 that we saved you. Keep in mind, all of these agreements are pre-negotiated, so there really is no discount. The insurance companies want a gigantic initial charge so that they can charge for any savings they can achieve. If we have prices on the website where everyone can see them, then discounting those prices is an opportunity foregone. And that's why the insurance companies don't want to work with us. And the hospitals, they grant insurance companies these discounts off their charge master as long as certain volume requirements are met. So many patients come through, or so much revenue comes through a hospital from Blue, United, or Cigna, or Aetna, then the deal that we made at the beginning of the year is still good. To the extent that you don't send us that volume of patients or volume of revenue, then there are penalties that the insurance company pays to the hospital.
Okay, so the hospital is imposing these penalties.
That's right.
You make sure the patients whose lives you're covering, you make sure they come to this facility.
Right.
Okay.
And that's another reason why the insurance companies are desperate to keep patients out of our facility or anyone else they're not contracted with, because they face these penalties for non-compliance of the volume requirements. So there's a lot of shenanigans that are going on that move patients around. And when Joe Schmo signs up for Blue, United, Cigna, or Aetna, they have no idea about all of the behind the veil sort of incentives and money changing hands that limit their choices, limit where they can go. And then they have these huge deductibles. They're paying a fortune for these policies. And many times they're part of a self-funded plan, and the employer is paying the other half of it that the employee never sees. It's a scam, and these people deserve all the thumping that they get. The federal government has created this mess, and I think that's important to remember, because when they ride in on their white horse and say, we're here to fix this, we can scratch our heads and move on to some solution that doesn't involve them.
Yeah, that is absolutely what you have done, walking away from the hospital and your practice and starting this organization. I'm really curious, when you and your partner launched the surgery center, how did you get these surgeons to come with you?
Well, we had great working relationship with about 10 surgeons, and they walked out with us. So when we walked out and started this facility, these surgeons wanted to be part of a facility that Steve Lantier and I were going to run. They had seen the anesthesia service that we could deliver at the hospital, and they wanted every bit of that they could get. So we not only delivered efficient anesthesia service, we delivered the efficient running of an operating suite. We had 10 surgeons join us, and we can say it's been a success because right now there are 107 surgeons on staff at Surgery Center of Oklahoma. So we started with 10.
Wow.
Now there are 107 surgeons who want every bit of this that they can get. They hate working anywhere else because we're extremely efficient and we take really good care of their patients financially and medically, and people travel from all over the United States. Self-funded employers pay all the travel costs and the entire bill for their employees who come to Oklahoma City and have their surgery.
Oh, that's so cool. That's so fascinating.
Yeah, and we're not alone.
Oh, say more. You'd think this would spread like wildfire.
I wouldn't say it spread like wildfire, but it is spreading. We've been missional from the very beginning. We wanted everybody to do this. Even the hospitals here in Oklahoma City are beginning to jump on board, and I'm working with them, connecting patients with them for a bundled price for inpatient procedures we can't do. So this is very powerful. These ideas are extremely powerful, and these hospitals that have traditionally been our enemies are now coming on board. And that's what the free market does. It makes everyone who works nice together friends. These ideas are spreading. They're spreading all over the United States. They're spreading slowly because the inertia that's out there, the headwinds are unbelievable, not just from the federal government, but locally with these sort of cartels that are out there between the insurance and companies and the hospitals.
I did a podcast on the pharmacy benefits managers. I did. It was
that's gross.
Gross. It was 13 ways that pharmacy benefits managers steal your money and hurt your patients, or something like that was the title. I didn't expect to do 13. I had interviewed Barbara McEnany, a former AMA president, and she had 7 or 8 that were just infuriating her, which got me interested in doing a podcast about it. But it sounds like so much of the same game plan, jacking up the prices so that you can say that you've discounted them, and everything done behind closed doors. I have no idea really how hospitals or how these PBMs get away with the complete lack of transparency.
Well, they've bought those favors in Washington, D.C. Our liberties have just been auctioned off one after another. And it's been both sides of the aisle too.
And like the big PACs, the lobbyists, the AHA and...
Yeah, I mean, the medical lobby in Washington, money-wise, is bigger than all other lobbies combined, including defense. It's just gigantic.
Yeah, there's kingdoms that have so much to lose if they are tackled head on, which certainly is something you've done, tackling them head on. What's the worst blowback you've gotten?
I don't know that I'd say we've tackled them. I think it's more accurate to say we have seceded.
Mm-hmm.
We've unplugged.
Yeah.
I mean, no part of my day or life involves insurance companies. I don't deal with Medicare. I don't deal with Medicaid. We've just unplugged, and we've just gone a different path, and all of that junk, it's out there. I hope more and more people do walk away. The blowback we received actually in our early days when we were filing insurance claims out of network. And that's when we were attacked severely by the hospitals, by the insurance companies. Even the state health department was weaponized by the hospitals and insurance companies to come after us. At one point, we had to sue them.
What happened?
Well, the state health department told us they wanted all of the medical records for patients we had operated on at our facility in the year 2000. And I told them no. And they said, well, you don't get to tell us no. And I said, well, you can't have them. And they said, well, then you're closed. And I said, well, we'll see about that. So we filed suit, and in discovery found they did not have the statutory authority to collect those records at all.
Well, what were they shutting you down for?
Well, they were shaking us down because they wanted to know the zip codes. They wanted to know our demographics. They wanted to know where are all these patients coming from that are going to Surgery Center of Oklahoma. They wanted that information on behalf of the people who were on their board who represented the hospitals and insurance companies. So we just sued them. I have their surrender framed on my wall in the office. We haven't really received any blowback for posting prices, but the real vicious attacks we received were early on when we were actually filing claims. I mean, we've never taken a dime of money from the federal government, so they don't even know I exist. And we don't file insurance claims anymore, so the insurance companies don't care.
And when did you stop filing insurance claims?
2010 or 2011.
Okay.
And then there was a brief period that we actually went in network with an insurance company because someone put pressure on them. Worst mistake we ever made. Thank God they terminated us. And that was a day to celebrate.
What made it the worst mistake you ever made?
People don't understand there's a lot of risk dealing with Blue Cross, United, Cigna, Aetna. I mean, you perform a service in good faith after you've jumped through all their hoops with pre-certification and pre-authorization. You perform the service. Let's say it's a cochlear implant. And, the device is $25,000 and you've been assured that this is medically necessary, indicated, and that they're going to pay. The patient has the surgery, they walk out of the facility, you file the claim, and then the insurance company says,
wow,
no, we're not going to pay for that. We've taken another look at this. We're not going to pay for that. So then you get to go after the patient. Well, your $25,000 implant just walked out of the door, and the patient may not have $25,000. So that sort of a thing. And then you say, hey, here are these 35 claims we filed that have not been paid. We never got those claims.
Yeah, they're doing the insurance denial thing to everybody.
Yeah, it's a joke. We all need healthy boundaries. And in my life, it's just good to have a boundary. And, Blue, United, and Cigna, Aetna, they just don't step over that line. They're not part of my life.
That is so funny. And the way you say Blue, United, Cigna, Aetna, what's the common denominator? Why those four?
They're the only four left. The Affordable Care Act implemented this minimum loss ratio. This, you can't spend more than 30% of your revenue on administration if you're an insurance company. Well, that meant the big boys could tolerate that and the little companies could not. So poof, suddenly there were four. And wherever you have industry consolidation, there's a smoking gun of some bribe handed to somebody in government at some level. The industry folks refer to Blue, United, Cigna, Aetna as BUCA. So if you ever have someone on your podcast who's from the self-funded industry, they'll say BUCA, and that's what they're talking about, Blue, United, Cigna, Aetna, and it's not complimentary. Okay. BUCA is a bit provocative, but that's...
What language should I look that up in?
Well, I believe that's how I'll refer to them for the rest of this podcast if it comes up again.
Okay. Okay, got it. I'm betting that it would make sense for me to ask you to describe self-funded programs, employers that have self-funded health plans, what that is about, and then why you are attractive to the self-funded plans.
Yeah, so self-funding is when a company, rather than paying United, take the risk of their employees' health needs. That company pays all of the employees' medical bills out of operating revenue. So rather than paying a company to take the risk for you, that company takes the risk themselves. Typically, these are companies that are 100 employees or more, and they look at, here's what's going out the door for premiums, to Blue Cross or whoever. Why don't we just pay that to ourselves in a separate account and pay our bills out of that?
Do they use the insurance company as a middleman then, or somehow
Yes.
Okay.
So what they also do is they buy a huge catastrophic policy that in case something goes terribly wrong, then they have a backstop, kind of a Lloyd's of London stop loss is what it's called. Let's say this company makes tires. Well, they don't want to get into the pay medical claims business. So they hire an administrator, and that can be an independent administrator, someone like my friend Jay Kempton. It could be an administrator that is part of BUCA. So you'll see Cigna have a contract that is ASO, Administrative Services Only. So this tire company throws the checkbook to Jay Kempton, and Jay Kempton then pays all of the claims on behalf of that company. So self-funding is when a company pays for their employees' health needs out of operating revenue, whether they do it themselves or they hire an administrator to do it for them. If you think about that, that means that employer has the same sticker shock that an individual does who has a high deductible or has no insurance or is part of a cost-sharing ministry. So self-funded companies have a lot of sticker shock. They really do care that it's priced fairly and that it's high quality. And so while I'm interested in self-funded companies, they are really interested in me. Mm-hmm. They were very, and still are very attracted to our website pricing because they can look back and they can say, wow, here's a laparoscopic cholecystectomy for $5,865. Didn't we pay $42,000 for one of those last month at Hospital X? And so that means that would have been $37,000 or $38,000 of revenue that did not go out of the door of that tire company. So self-funded companies they love this. They love the transparent pricing and the high quality, and they are flocking, and actually they're demanding it even from facilities that are not providing upfront pricing. They're demanding it from them because thanks to what I think we started, they know it's possible.
When they have sticker shock, is it coming from the insurance company or is it coming from the hospital system or a healthcare system?
Well, it's coming from both. The insurance company comes in, the broker comes in and says, you had a really bad year last year, so your renewal is going to be up 28%. So the employer's shaking their head thinking, wow, I pay a ton of money and it's going to be 28% more next year.
And that's from BUCA.
That's from BUCA and the broker who is selling that crap.
Okay.
Also, that broker's commission is linked to the premium.
Yeah.
So if the premium goes up, it's horrible news for the broker to deliver to his so-called client. The broker is making out like a bandit on bad news.
Like PBMs. I mean, this is
same sort of thing. But the main sticker shock's coming from the hospitals.
Okay.
So person has a total knee replacement, and it's $100,000.
So they don't discount it for the self-funded.
They do, but even after they discount it, okay, it's $42,000. Well, they could have bought that at Surgery Center of Oklahoma for $15,499.
Is that the right price? You've got
Yeah, that's the price online. So as word gets out and these prices, like the ones listed at the Free Market Medical Association's website, at my website, as these prices are more known, self-funded employers realize, whoa, we paid $70 and we could have paid $7, or we paid $60 and we could have paid $12.
What's the most outrageous spread that you've seen between your pricing and how it's priced elsewhere?
10-to-1 is real common. For some reason, the Dallas-Fort Worth area tends to be really, really expensive, and they're real close to Oklahoma City. So we have done very well on patients from North Texas who are fleeing that pricing. The story I've told over and over, we had this patient from Georgia who was quoted $40,000 for a urologic procedure that was $4,000 on our website.
There you go.
And he didn't come here, but his urologist used that information to get a price match in Georgia.
Yeah.
So the patient saved $36,000 and emailed me at one point and said, you realize you saved me $36,000 and you didn't even perform the surgery. Mm-hmm. But, that was one of our goals. We really wanted to start a price war, and we wanted the sticker shocked to better find us. And we wanted to understand these scams better. And not all of these goals have been achieved. And these ideas are powerful. Anybody listening to this would do themselves a favor to familiarize themselves with the writings of Murray Rothbard. He's a brilliant economist. But he referred to the free market as both beautiful and powerful. And I'm witnessing that. I feel vindicated in seeing these ideas spread, even amongst the price gouger. They have to embrace these market ideas or they're losing business. So they find themselves with boundaries that have been imposed on them that I believe are much healthier. And these ideas are powerful, and that's why I remain optimistic. I'm as optimistic as I've ever been because I'm seeing this idea of price transparency, high quality, seeing these ideas spread. And it's very, very cool to see.
Very exciting. We often hear that this institution or that practice needs to be so-called, in quotes, run like a business, and that doctors should just see patients and let people that really know what they're doing, run the business. And what I see here, and I call it the business school mindset, it's really an ideology that comes out of business schools, which is profits uber alles. Everything is about make as much money as you possibly can off the backs of other people. What do you think of this whole idea of MBAs or business-oriented people who don't have any experience in medicine running our profession?
There are two models in this industry. One is championed by the vast majority of hospitals, and that is revenue maximization. So how do I make the most money? The other model is how do I maximize the delivery of value? That is the model that I champion. If you're in a free market, free and functioning market, and you come across someone who really doesn't care about what service or product they deliver, and all they care about is stripping your wallet as hard as they can, then the market is very harsh with an institution or a business like that and judges them very harshly, and they tend to go out of business. If you went to an automobile dealership or a car repair, grocery store, whatever, you just wouldn't go back. And the word would get around and no one would go back and they would go out of business.
Right.
So in a free market, the person whose vote you have to acquire is the buyer, and it's the patient. So what we're seeing is a situation where the market is not at work by and large, and that allows the entry of business people who can then sell whatever knowledge they think they have that allows us to better navigate the disastrous morass that has been thrust upon us.
Mm-hmm.
If you sweep all of the chaff out of the way, then it's pretty easy for physicians to deal directly with patients and say, here is what I do and here's how much it is. I mean, think about the direct primary care movement. Is there anything more simple than you pay me $80 a month and you can see me as much as you need to? End of story. Where is the business manager? They're not needed. It's that simple.
You certainly spell it out as being extraordinarily simple on the business end of things. And I have to say, I hear that from almost every physician that I interview who has founded their own center or has done something really extraordinary like you have. There's some automaticity to putting patients first. I think that really informs decisions. Do you have thoughts on that?
Well, if you don't put your patient first, they're going to pick up on that, and then they're going to go see someone else. If there's someone else to see, but the market has been so thwarted in so many ways by so many of the cronies and people in government. I mean, look at certificate of need laws. These have prevented surgery centers like mine from opening in about 37 states. Wow. So they have certificate of need where you have to basically appear before a star chamber of people who don't want you to come into existence because you'd be competing with them.
There wouldn't be any American Hospital Association lobbying on that behalf, would there?
No, you think?
I wonder if you could talk about the culture of the surgery center. In my intro, I said that 40 of the finest physicians in Oklahoma own the surgery center now. And then you mentioned over 100 docs. So can you package all that for me so I understand sort of the structure? And then I'll ask you about the culture.
Yeah, our partnership is a true partnership set up basically like a law firm.
Mm-hmm.
And there are actually, I think there are now 36 owners, but we pay so handsomely for the professional fees for procedures performed at our place that everyone wants to work there. So, for instance, when you look at a knee arthroscopy, our price is $3,740. The portion of that goes to the surgeon who's actually doing the work is higher than any insurance company pays him or her. So
the proportion is, but how about the absolute dollar amount?
The absolute dollar amount that goes in the surgeon's pocket is more than any insurance company pays them, even though our total price is $3,740. So if a patient walks into a surgeon's office who does not work at our place, and they say, hey, I'm part of this self-funded plan, and if I go to Surgery Center of Oklahoma, they pay the whole bill, that surgeon knows he's going to lose this patient if he doesn't come to our place. And if that surgeon is any good, if they're good, we'll let them come. If they're not good, I won't let them come. And we know the whole area, so I know who to call to find out if we should give them privileges or not. Then that surgeon finds out, whoa, this is what you're paying me for a knee arthroscopy? That's unbelievable. And then I've got them. I mean, why would they want to work anywhere else? It's efficient. They're not having to chase patients around the block to get paid. They're being paid very handsomely. And so that's why our medical staff has grown. We still just have, I think, 36 owners.
Okay.
But that's how we've come to be a staff as large as we are.
And do those doctors, the ones that are not owners, do those other physicians work in other places?
Yes. And I have, how many employees do I have? I think I have 42 employees. The Surgery Center of Oklahoma is self-funded. And so we pay all the medical bills for our employees. They contribute nothing out of their paycheck to our health plan.
And how is their paycheck?
Their paychecks are very strong. We have very little turnover, almost none. And we don't have any trouble hiring people. I mean, hospitals are horrible places to work. They always have been, but especially now. And our place is wonderful. It's just like you come to work for us, you're part of the family.
Prove it that it's wonderful. How do you know you're wonderful as an organizational culture?
I think the best proof is that any employee that needs surgery has it done at the Surgery Center of Oklahoma. They know their colleagues, they know the scrub techs, they know the circulating nurses, the pre-op, the recovery room nurses, they know the anesthesia team, they know the surgeons who are on staff there. They've seen Dr. Lantier and I kick surgeons out of the surgery center who were not competent or who were unethical. So they know our prime mission is the delivery of quality care and that the revenue is secondary. We happen to believe if we provide quality care that the money will take care of itself. And we always have believed that. And we've always promised each other that if it ever goes upside down, we'll just close it. You know, in Marty McCary's first book, Unaccountable.
Is that how you pronounce his name?
Marty McCary?
McCary?
Yeah.
Oh, no.
Oh, I had it wrong for a long time. But in his first book, Unaccountable, he said that's the best way to figure out if the place is any good, is ask the staff there, would you have this procedure done in your own facility?
Absolutely.
Yeah.
Yes.
So I think that's the greatest tribute that I can give the facility.
And how much fun do people have there?
It is an extremely fun place. We have patients all the time who just shake their heads. They can't believe everyone has a smile on their face from the time they check in through pre-op, in the operating room, in recovery room, everyone has a smile on their face. More than 2 or 3 times a week, some employee will tell me, this is the best job I've ever had. So it's a very upbeat place. If there are patients that are unreasonable, we don't let them come back either.
Wow. This is like Southwest Airlines.
Yes. I read the founder's book called, I think it's called Nuts.
Yeah, nuts.
You have to have a happy and healthy staff in order to deliver a great service. So if there are surgeons who are jerks, we just kick them out. If there are patients who are jerks, we don't let them come back.
Wow.
And because that culture matters, and the care that people receive is definitely enhanced and bettered by a healthy and happy staff.
I totally agree with you that you can't get a better marker of high quality than the people that work there, and probably especially the physicians seeking care there themselves. I mean, that's a clincher as far as any physician is concerned. But externally, how would patients know that you guys are any good?
Well, OSMA, the Oklahoma State Medical Association, is kind of like a state version of the AMA. It's the physician organization for the state of Oklahoma. They offer a health plan to the members and to their staffs. And if any of the physicians or their staff need surgery, then they can come to Surgery Center of Oklahoma with no out-of-pocket. That is a reasonably accurate, I would say, or easy thing to wrap your head around in terms of what do people really think of us. It's a wonderful place. We do all kinds of stuff. The staff is happy. The patients are happy. So people can look at our reviews on social media. It's just one after another. And I don't know of a health facility that has reviews like we do on social media.
Oh, I'm going to have to jump on and take a look at that. That sounds really cool. So shifting gears, the name of the podcast is Licensed to Lead. In my opinion, physicians need to be running healthcare. And I'd like to hear your perspective on physician leadership.
Yeah, I don't know that it matters so much whether a doctor is leading the organization or not. There is certainly an advantage in that if a physician is running an organization, he already has some clinical knowledge that a business person would not have. Mm-hmm. If a physician is running the organization, that also is a disintermediated model where there's one less mouth to feed. So if you don't have a business person involved, he's one less mouth to feed. Right. So efficiency-wise, yes, physicians should run it. Clinical knowledge-wise, yes, physicians should run it. More importantly, as my recently deceased father used to say, you start with a philosophy, and then the methods and the goals flow from there. If you have a businessman or a businesswoman with a philosophy of mutually beneficial exchange, then they probably will run a center or a hospital or a practice just fine. The problem with a lot of business people is they tend to be revenue focused. And they come at it from how do I maximize revenue rather than an operating philosophy which generates methods and goals. I would say the operating philosophy is more important than actually who's wielding it.
And so that would lead me to suspect that you've seen some really superbly run hospitals or practices where the physicians are employed. You've seen some excellence there at the hands of a business trained president or CEO.
Yeah, I mean, that's either because that person has a mission, either that was self-generated or is consistent with the physician owners, and they're carrying it out. I don't have any problem with that.
And you said physician owners, but what I'm talking about is where the physicians are not in charge. They're not owners.
Yeah, if the physicians are employees of the hospital, yeah, that's a disaster. If you're a physician working for a hospital, you're working for who's paying you. You're working for the hospital. I mean, there's a real conflict of interest there. And when when what's best for the patient or what's best for the hospital conflicts, you're in a battle we should never even be in. And eventually many physicians succumb to that and they do what their employer wants them to do, what's not necessarily best for the patient. You're a primary care doctor and somebody needs their gallbladder out and you want to refer to the best surgeon and he's not working in that hospital. Well, God help you if you refer to that surgeon. You better refer to the surgeon who is actually a fellow employee in that hospital, whether he's any good or not. So these kind of things happen every day. I don't think I'm overstating that. When administrators own the hospital and they own the doctors, my gosh, in some places, the hospitals also own the insurance company. Right. It's really, the patients are completely disenfranchised.
Yeah. Unlike the physicians working in your institution, where I bet they're joyful, they're fulfilled, they're doing what they love to do.
They're doing what they love to do.
Yeah, that's not available. And it's sort of sneered at. I mean, 70% of physicians now are employed.
Yeah, it's way too many.
What would be the right number?
0.
Okay. I'm with you. Well, clearly you are a brilliant business person and strategist. And where did you get your MBA? Let's give them credit.
No MBA here.
Okay. I want you to tell us where people can find you. Where can they hunt you down and get information that you want them to have?
Well, Surgery Center of Oklahoma is on social media, on Facebook, LinkedIn, Twitter. Our Twitter handle is @SurgeryCenterOK.
Do you write those tweets?
I do. Yeah. Anything you see on any of the social media, I wrote. So
that is funny.
And I usually put my initials after anything I write. I'll write GKS. If you see that, then I absolutely wrote it.
And what does that G stand for? Are you telling?
My first name is George. I go by Keith.
Okay.
And then our website is surgerycenterok.com. And then people need to check out the Free Market Medical Association. That's fmma.org. All of the prices for all of the facilities that are participating in this movement are there.
That's great.
And if somebody wants to see inpatient bundled pricing that I've arranged, that's at atlasbillingcompany.com. It's a good place to look at bundled prices that have been arranged at hospitals. So these are people whose day job is price gouging, but behind the curtain, they're making deals with me for the benefit of individuals and self-funded employers. And that's a very healthy thing that's going on.
Well, thank you so much. This has been just a delight and really an education.
Well, thanks for having me. Send me a link and I'll get it out on all of our social media as well.
Super. Thank you.
Thanks for listening to the License to Lead podcast. Be sure to visit licensed2leadpodcast.com to join the conversation, access the show notes, and sign up for our newsletter. Leave us a message with your provocative question or your thoughtful comments. You might inspire a future episode of the License to Lead podcast. Thanks so much, everyone.